Recording in
And
progress.
We actually did it last year. So cholesterol can be synthesized de novo from acetyl-CoA in the liver, and the rate limiting step is characterized by hydroxymethyl-glutyl-CoA reductase. That is what you call the committed step. You go past that, then you are making cholesterol. So this enzyme is regulated by intracellular cholesterol levels by means of feedback inhibition. Triglycerides, on the other hand, are derived from dietary fatty acids, which are exogenous sources, and from the liver. We remember when you take a diet, when you take a meal, it contains lipids. There is requirement for transport of lipids from the GIT to the peripheral tissues. And therefore, there is the elaboration of chylomicrons in the mucosal cells. And now that is what is called the endogenous pathway of lipoprotein metabolism. Then the other one is the one which is synthesized in the liver because of increased availability of calories. And this is the endogenous pathway. And in this case, instead of chylomicrons, you end up producing VLDL, which will then go to the step of deripidation by lipoprotein lipase, and you get intermediate density lipoprotein, which eventually is going to lose most of its triglycerides plus the apolipoprotein E and end up as low density lipoprotein, which is LDL, with only ApoB on the surface, which is supposed to be the structural apolipoprotein on the LDL. So this utilizes fatty acids synthesized de novo, and from fatty acids derived from the adipose tissue. So this is not dietary, it's within. In both cases, triglycerides are transported to target tissues in plasma. Lipoprotein system is involved to solve the problem of transporting lipids in the aqueous environment of the plasma. We said last year that lipids are insoluble in water, and because of that, it's difficult to transport them from point A to B in an aqueous environment. Therefore, there is the requirement to elaborate these particles where the hydrophobic lipids like cholesterol esters and triglycerides are in the core of the particle. And on the outside, you have got the lipophilic groups like the phospholipids, the free cholesterol, and the proteins. These can interact with water, and therefore you can get the particle to move in an aqueous environment. Now, lipids are generally hydrophobic and therefore insoluble in water. Only the charged phosphate group of the phospholipid and the hydroxyl group of the free cholesterol are hydrophilic. And these are the ones we are saying they are outside the core. We shall look at what is called the iceberg, phenomena. Lipids are therefore transported in plasma as lipoproteins, which are usually complex spherical structures with a hydrophobic core wrapped in a hydrophilic. I change that to hydrophilic. It's the core which is hydrophobic. The coating is actually hydrophilic. The core contains triglycerides and cholesterol esters, while the surface contains phospholipids, free cholesterol, and proteins, which we call the apolipoproteins. In the iceberg model of plasma lipoprotein, the polar heads are exposed to the aqueous environment, and the neutral TGs and CEs, or the cholesterol esters, are localized primarily in the core of the particle. The iceberg model, you look at the sinking of the Titanic. The Titanic, what the captain actually saw was just a little bit of ice on the water. And he didn't realize that this was just a tip of the iceberg, and that's how it sank. So what you get in the plasma lipoprotein is those crops or heads of the phospholipid, free cholesterol, and the proteins. Lipoproteins vary in size, density, and electrophoretic mobility. And these properties have been utilized in the separation of lipids. The size starts with the chylomicrons, which are quite large. You can even visualize them under microscopy. And the density goes down as you go from the chylomicrons all the way down to high density lipoprotein. It's called high density because it sinks further on centrifugation. The gold standard for separation of lipoproteins is actually preparative atherosclerosis. And the lipoproteins will be separated based on the hydrated density. So the chylomicrons, which are quite large, will remain at the origin. Then you get the VLDL, you get LDL, and then you get all the way down to HDL. And of course, now the density will depend on the amount of protein each of these lipoproteins have. Chylomicrons have got very little lipoprotein, very little protein. VLDL will probably have something like about 10%. Then you go down to LDL with about 25%, and then you have got HDL with about 50%. So that's why it's actually the high density. Now the problem with this technique is that it's time consuming. It requires a lot of expertise, and therefore the turnaround time is also very poor because we are probably talking of 12 to 24 hours, which again in medicine is not acceptable. So in the lab we use electrophoresis, and the separation here is based on charge. Anytime you hear about electrophoresis, it's about charge. You have got two terminals, an anode and a cathode, and the movement will be based on the charge. The more the number of charges on the surface of a particle, the faster it's moved. Unless now you're talking of using of gel, where you can separate using charge and the pore size or the size of the particle. Now, these physical chemical properties are determined by their relative content of total triglycerides, cholesterol, phospholipid, and protein. So either way, the movement of the particles in an electric field will mimic that one of the separation of preparative atherosclerosis using hydrated density. The more the protein you have on the particle, the fastest it's going to move in an electric field. Again, chylomicrons with neutral fat will remain at the origin. Then as you go down, there is increase in charges because of the increase in protein content. Remember, proteins have got two charges, a carboxyl and an amino group. So that confers more electrical activity. The most triglyceride-rich particles, like the chylomicrons and the VLDL, chylomicrons are so large, about 1.2 millimeters in diameter. you can actually visualize them under light microscopy. VLDL is also triglyceride rich, but it's not that big. But they scatter light and impart milky appearance to plasma. We shall revisit this issue later as we go on. They are of such low density that they float to the surface of the plasma on standing. When I started looking at lipids, we were actually using what was known as the Thorpe interferometer to measure the flotation constant of the particles. That was a long time ago, and the science have actually moved so far away that the Thorpe interferometer, a lot of people haven't even seen it. They have not even heard about it. The lipid content is metabolized during circulation in plasma, and some of the protein content is exchanged. Now, I just had a small diagram here, and what it says is in the process, one type of lipoprotein is gradually changed to another type of lipoprotein particle. If you remember what we said in third year, that there is the lipoprotein cascade where particles are exchanged, they are given and exchanged. So you get particles like ApoC moving to HDL, HDL donating ApoA and ApoC again, and then also the lipoproteins passing over some of their triglycerides and cholesterol to HDL. So it's a give and take process. So we have got the different lipoproteins here, and I decided to just show the density as what was actually called the flotation constant. If you look at the kilomicrons, the density is less than 0.96 grams per ml. Electromobility or electrophoretic mobility will be at the origin, no movement at all. The lipoprotein of the surface is ABCE. Contribution percent of each of the different lipids and protein. We have got cholesterol, kilomicrons has got 4, triglyceride 90, usually 80 to 90%, protein 2, and the main function is to carry exogenous triglycerides. VLDL, on the other hand, ranges between, on centrifugation, 0.96 to 1.06. If you're using preparative ultracentrifugation, you have to keep on changing the density of the separation medium so that you can get the different densities where each one of these particles is going to appear. On electrophoresis, it appears as pre-beta. That's pre-beta movement. Then ideal will be in between pre-beta and beta, and you can see the different lipoprotein and the different the different composition. Then the main TG is the main triglyceride for carrying endogenous lipids is actually VLDL. Then you can see LDL there, cholesterol content 50%, very high, as the main cholesterol carrier. HDL, you can see the density 1.063 to 1.2, so it will actually separate in that region, and it has got an alpha movement on electrophoresis. Then you have got the lipoprotein A, C, D, and E, and total protein content of 50%. So it's quite high, and it carries cholesterol from non-hepatic tissue to the liver. We shall visit that one again. Now, lipid transport and metabolism in plasma. The main function of plasma proteins is to transport lipids from the site of synthesis to site of storage and utilization. During circulation, processes of change in shape and size occur on the originally secreted lipoproteins and result in formation of new particles. That is the lipoprotein cascade. And these processes include transfer of apolipoproteins between lipoproteins. I've just seen that HDL is usually described as the carrier for ApoC because it keeps on giving it out. And you know, ApoC is quite important, particularly as a cofactor for lipoprotein lipase. Transfer of lipids between lipoproteins, between one to the other, and we shall see this particularly when HDL corrects cholesterol from the periphery and it enters into its hydrophobic region or hydrophobic core. What it's going to do is it's going to lose some of the cholesterol ester to the triglyceride-rich lipoproteins, chylomicrons, and VLDL through the cholesterol ester transport protein, or CETP. Metabolism of lipid content by enzymatic action, hydrolysis of triglyceride by lipoprotein lipase, and hepatic triglyceride lipase, which is HDL, and esterification of free cholesterol by LCAT. And this, the last one, usually occurs within the nascent HDL, where you create lipids, because when HDL is released, it's usually lipid sharp. It doesn't have any lipids. It's only got lectin and ApoA. But it's in close association with lectin cholesterol transferase. And what it does is to produce a free fatty acid moiety, which esterifies free cholesterol to esterified cholesterol. And the other is clearance of lipoproteins from plasma fire receptors, mainly in the liver. We have seen the action of the BE receptor. We have seen the action of the B receptor in internalization of LDL into the cytoplasm, fusing with the lysosomes, and eventually release of cholesterol into the biliary tract and loss of the same in the fecal material. The operation of these different processes can be conceptualized as three interconnected cycles or pathways of lipid transport. The first two we have actually done: exogenous cholesterol transport from delivery of for delivery of dietary lipids to the tissues. That's what we are saying, the elaboration of chylomicrons to transport, because of a need to transport dietary lipids to the periphery. We have seen that, and that one, the endogenous cholesterol transport for delivery of hepatic lipids to the tissues. That is the production of VLDL, which is then eventually going to get into plasma and undergo degradation or catabolism through IDL to LDL. And of course, eventually deposition of lipids into the periphery. Now, the last one, which we have not done properly, I'm not going to go into depth, but I would actually want you to look at it, because this is the mainstay of the protection of LDL or of HDL against coronary artery disease. We usually say that there is a reciprocal relationship between LDL levels in HDL levels in plasma and development or risk of development of coronary artery disease. And this is usually done through cholesterol, reverse cholesterol transport for return of excess cholesterol from the tissues to the liver. Remember, LDL is the main carrier of cholesterol, and it's going to deposit its cholesterol in the tissues, including the fasciculature. You can see where the flow becomes sluggish, the bifurcation of the aorta. Around these areas, deposition is going to take place. HDL is a small particle, relatively, and it's going to penetrate the intima, and through the action of LCAT, it's going to pick up cholesterol and esterify it. But before that happens, there is what is known as ATP binding cassette A1 and G1. And these usually allow the influx of the deposited cholesterol to get into the HDL particle. The same thing will also happen through what is known as the scavenger receptor, which is usually on the macrophages. And macrophages usually get recruited from monocytes, and they pick up cholesterol, they imbibe cholesterol, which is not controlled by any feedback system, and eventually it's going to download its load of cholesterol to the HDL, and the HDL is going to pick that and it's going to take it to the hepatocyte. It's going to inject its cholesterol load through these receptors like the SARIs, the scavenger receptor. Then it's going to be released back without its cholesterol load as HDL3, which is relatively large, lipid shy, and on the process is also going to start losing, gaining lipids, and it becomes a smaller particle known as HDL2. So I would want you to look at this process. It's a little bit more complex than I have just said, and you probably understand the protective role of HDL in the development of coronary artery disease. Now let's look at the role of hyperlipidemia in atherosclerosis, because basically why we study lipids is because of its association with development of atherosclerosis and coronary artery disease. Most of the hyperlipidemias result in accelerated atherosclerosis, chiefly coronary arteries and the aorta. This may also affect the renal, carotid, the iliac, femoral, and other arteries. Atherosclerosis refers to the underlying disorder involving the intima of medium-sized and large arteries. This leads to accumulation of lipid, mainly cholesterol, and cholesterol-laden macrophages, which are usually described as foam cells. And if you carry out autopsy, you should actually see these foam cells, which are laden with the lipids, and the development of a raised fibrous region, which narrows the arterial lumen. This may eventually compromise circulation to the heart, coronary artery disease, brain, cerebral vascular disease, kidneys, renal artery stenosis and hypertension, and extremities, which is a peripheral vascular disease, especially when complicated by rupture and thrombosis. Coronary artery disease is the commonest cause of death and early invalidism in the Western society. A number of risk factors for the development of coronary artery disease have been identified and will include increasing age, male gender, family history of coronary artery disease, hypercholesterolemia, cigarette smoking, hypertension, diabetes mellitus, obesity, sedentary lifestyle, and others including hyperuricemia, use of oral contraceptives, and abnormal fibrinogen levels. Now, when you look at the factors 1 to 3, which is increasing age, male gender, and family history, they cannot be altered. These ones are there, you cannot alter them, because the remaining factors are modifiable. 4 to 6, that includes cigarette smoking, hypertension, are primary risk factors. And each one of them can be separately be linked to coronary artery disease. 7 to 9, which is diabetes, obesity, and sedentary lifestyle, are secondary factors. And what they usually do is to worsen pre-existing coronary artery disease. Now, presence of a risk factor does not mean that coronary artery disease will occur, but increased likelihood of developing CAD. So they are not actually causes. Most risk factors are continuously related to development of coronary artery disease. So there is no threshold value which is normal, and below which there is no risk whatever. So the whole thing is continuous. Smoking and hypertension are approximately double the risk of developing coronary artery disease, while hypercholesterolemia trebles it. So to be multiplied 3 times. The hypercholesterolemia of familial hypercholesterolemia as FH, which is now type 2A, increases the risk 100-fold or more. One time I was in Cape Town. They have got a lipid clinic there. And what you find is people walking into the clinic with levels of cholesterol of 40 to 60 millimoles per liter. And I was baffled. I've never seen anything like that. Here, the levels we find elevated levels 12, 13, 15, and we think, wow, what's going on here? But in South Africa, they have got what they call the founder's gene, which is the FH gene. And the founders are the Dutch, who came from Netherlands, went to South Africa, and they became Boers. We know about them, and the way they came up through Zimbabwe, came up to Kenya, went as far as Eldoret, where they were growing wheat and maize. So the understanding is these people must have spread the FH gene along the region. The penetrance, we are not sure how it is, but it's certainly there. So is there one common pathogenic mechanism linking these risk factors together? The atherosclerotic process is started by endothelial injury leading to endothelial cell dysfunction with increased permeability and adhesion molecular expression. You remember that theory of FACO and FACO. You must have done it in histopathology. Once in the intima, lipids and lipoproteins are modified by oxidation. Now, the story goes that oxidized and acetylated LDL is able to puncture holes through the intima, and that actually creates an endothelial injury. So they are then ingested by macrophages via the macrophage scavenger receptor SRA1, which only recognizes oxidized or acetylated LDL. The macrophages will preferentially imbibe oxidized and acetylated LDL. So preferentially. Now this uptake is unregulated, with the macrophage eventually becoming a cholesterol-laden foam cell. They behave like ticks on cows. See, a tick will live for a long period of time, almost flattened down, or a bug, the usual bed bug. But when it gets to you, it's going to just keep on sucking blood and it bloats and bloats. That's the way the macrophage actually behaves as far as cholesterol is concerned, and particularly the oxidized acetylated form. During this process, the macrophages release inflammatory chemokines such as interleukin-1 and tumor necrosis factor, in addition to the growth factors, that's pre-stressed growth factor. Now, this stimulates migration of monocytes and smooth muscle cells into the region with generation of more foam cells and synthesis of collagen. The scenario events lead to the formation of mature atheromatous region. And this process is usually accelerated by one, high circulating lipids, cigarette smoking, which produce superoxide radicals, aging, endothelial damage, which can be caused by hypertension, toxins, viruses, immune attacks, and smoking. Additional risk factors for coronary artery disease are lipoprotein small a and small dense LDL. When we measure cholesterol or we measure lipids, most of the laboratories will measure for you total cholesterol, triglycerides, and HDL. That's usually standard. And most of our laboratories here have got the capacity to measure total cholesterol and triglycerides. Who has got a total cholesterol of 8 millimoles per liter, the chances are that the HDL cholesterol or the cholesterol carried by the HDL particle will be something like maybe less than 1 millimole per liter. If you assume it's 1, then 7 millimoles per liter is carried by something else, which of course you can see it's either LDL, IDL, chylomicron remnant, VLDL, and lipoprotein small a. Now, each one of these is an independent risk factor for coronary artery disease, the so-called non-HDL cholesterol. So when you subtract 1 ml of HDL cholesterol from 8 of total cholesterol, it gives you 7 millimoles per liter of non-HDL cholesterol. So what you are actually looking at is the atherogenic potential of that plasma. Now, the common denominator between all these atherogenic lipoproteins is that each one of them contains an ApoB on its surface. So according to WHO, the best mark for atherogenesis and coronary artery disease would be ApoB. The problem again is that this ApoB standardization of the assay mechanism is not very good. So up to today, WHO still insists that we measure LDL cholesterol as a surrogate marker for ApoB. Now let's see whether lipoprotein small a, its relationship with ApoB. Now lipoprotein small a consists of an LDL particle, the way we know it, the LDL particle with a B apolipoprotein on the surface. So lipoprotein small a consists of an LDL particle containing apolipoprotein B with an additional apolipoprotein known as small a or apo small a. So you have got two apolipoproteins joined to each other through disulfide bridges. So you have got ApoB, a disulfide bridge, and then another apolipoprotein A. Therefore, it also contains a copy of ApoB on its surface. This additional apo small a protein has marked homology with plasminogen. So it has got homology with plasminogen. It competitively inhibits the conversion of normal plasminogen to plasmin and is thus anti-fibrinolytic, fibrolytic, and favors thrombus formation. And that's now relates to the atherosclerotic part. Levels of lipoprotein small a are genetically determined, and elevated levels confer a threefold increased risk of coronary artery disease. Now, when it comes to LDL, there is large LDL particles. Then you have got others which are small dense, and you can separate these in the laboratory using various concentrations of separation material. And this has been so much, a lot of research has been done in this area, particularly by somebody read by the name of Melissa Cross, and she has popularized this issue of small dense LDL. And this confers a 3 to 5-fold increase for the same level of cholesterol as large LDL particle. So it's more atherogenic by 3 to 5-fold as compared to the other large LDL particles. So if you find a person who has got this particular type, then most likely you may want to investigate the patient further. You must realize that HDL also has got small dense HDL particles. But the interesting thing is that unlike small dense LDL, small dense HDL is particularly useful in the reverse cholesterol transport. So it's actually better than the larger type. So you have got to just realize that. Now, these occur in approximately 15% of the population and are associated with hypertriglyceridemia, low HDL cholesterol, and insulin resistance. And this is classic metabolic syndrome. Hypertension, increased waist-hip ratio, hypertriglyceridemia, hyperuricemia, hypo-alpha lipoproteinemia, and increased insulin resistance. Particularly with ladies, what they also present with is acne. They present also with polycystic ovarian syndrome or PCOS. So this is actually classical metabolic syndrome, or what is known as syndrome X. Now, for the lipid-related risk factors, the development of coronary artery disease therefore, these are the risk factors: increased total cholesterol, increased LDL cholesterol, decreased HDL cholesterol, increased lipoprotein small a, and maybe presence of small dense LDL particles. So this is would actually be an excellent case for development of coronary artery disease. Now, what are the indications for lipid investigations? When are you going to request for lipid investigations? The patient should be investigated for lipid disorders if, one, they have a positive family history of premature coronary artery disease that's occurring below the age of 55, have coronary artery disease, cerebral vascular disease, or peripheral vascular disease. Then you may want to find out the lipids, the lipid profile. Have any other risk factors for coronary artery disease, the ones we have just seen. Have any clinical signs of hyperlipidemia. Sometimes this is found accidentally. You are carrying out a profile and you find maybe one of the lipids is elevated. You may want to investigate the patient further. Have any conditions associated with the secondary hyperlipidemia? I usually say that the primary types of lipidemias are usually very uncommon. But what you are going to come across in your clinical practice, most likely, is the secondary types of hyperlipidemia associated with diabetes mellitus, hypothyroidism, nephrotic syndrome, lupus erythematosus, acute intermittent porphyria syndrome, liver disease, chronic renal failure. All these are most likely the areas to investigate as compared to committing resources looking for the familial type. They are not actually that common. They have pancreatitis or hypemic fasting plasma. Pancreatitis is, in most of the cases, usually associated with hypertriglyceridemia. The same thing with obesity. Most of the obese patients could even have normal cholesterol, but elevated triglycerides. Have increased cholesterol or triglyceride detected incidentally. A put history taking and examination are vitally important. Is your patient an alcoholic? Alcohol usually induces production of VLDL in the liver. And in mild alcohol intake, it's usually HDL, which is preferentially synthesized, which of course is good. But the problem is you go beyond a certain level, 2 beers, 300 ml, and now you start getting into areas where the liver is going to be induced to produce VLDL. VLDL lead triglycerides. And what usually happens is that there is a reciprocal relationship between HDL cholesterol and triglycerides. When you have got high triglycerides, the HDL is usually low. So the good effect of the 2 beers is completely cancelled by the excess intake of alcohol. Laboratory investigations available, EDTA plasma sample after an overnight fast are essential for TG, but not for cholesterol. Now, this should be taken with minimal pheноstasis, normal diet, no alcohol, no recent change in diet, weight, in exercise, weight, diet, and no recent history or injury. If a patient has been sick, then you should wait for a couple of months, maybe about 6 months, for you to let the levels of cholesterol find their way back, or the lipids. Now, the use of EDTA is, people ask, because In KNH, what we usually do is we shall use a print bottle to take a specimen. And the assumption in that case is that the lipids are going to be measured almost immediately. But I know cases where specimens are kept for a couple of days. Either you batch them because you are carrying out a study or something, and that usually leads to oxidation of the phospholipids. And to mitigate against this, use of EDTA is usually indicated. Recent acute MI or other events evoking an acute phase response within the preceding 6 weeks cause for low cholesterol levels. We have had cases where somebody has had a myocardial infarction, is recovering, and then comes to the lab, the levels of cholesterol are taken, and they are low. And it creates quite a misunderstanding what is going on. Without coronary artery disease and the MIs are usually associated with. But what usually happens is that there is an acute phase response, and this seems to interfere with the cholesterol levels. Now, lipid profile, when we talk of the lipid profile, generally we are talking about total cholesterol, phospholipids, and fatty acids because that's what are lipids. Lipoproteins are just vessels for carrying lipids, but we use almost, when we talk of HDL and LDL, we usually say it's a lipid profile, but we know HDLC and LDLC, they are not actually lipids as such, but they are usually done and they are presented. Relationship between risk of coronary artery disease and HDL came up around 1933, and it has been consistently proved that is actually true. Total cholesterol and triglycerides measured enzymatically. Before then, we were doing what is called chemical methods involving 3 very corrosive acids called Lieberman and Burkhardt. That has completely been surpassed or by the enzyme because they are more specific and easier to use. HDL cholesterol is measured enzymatically. After all known HDL lipoproteins are immunologically rendered non-reactive. LDL cholesterol is calculated using Fredwood's formula, which is there. And this is usually done when the HDL cholesterol measurement is certified to be correct. What I mean by that is, like I said, the levels of HDL cholesterol are quite low as compared to the total cholesterol. And when you start measuring below 1 ml or 1 millimole per liter, you are approaching what is called limit of detection. And the coefficient of variation usually goes up. The error component increases. So if you increase the error component in measurement of HDLC, it also appears as part of the LDL concentration. So it's usually total cholesterol minus HDLC minus triglyceride divided by 2.2. But this formula is only valid if the TG levels are less than 4.5 millimoles per liter. The minute you go beyond 4.5, and this may happen in cases of diabetes type 1, then it invalidates the equation. ApoA1, ApoB, and lipoprotein small a are measured either immunoturbidimetrically, nepherometry, or what is known as Lawlor's locket electrophoresis. Now, some patients will present with normal HDL, with normal LDL, but you have got that clinical suspicion that most likely there might be a problem with the lipids, and you may want to measure the levels of ApoA1 and ApoB. Now, the steam pressed way of checking for the different Fredrickson's classifications is by taking plasma, or rather, you take plasma or serum and you leave it overnight in the fridge at 4 degrees centigrade. The following day, if the creamy layer present, if there is a creamy layer present on top, that signifies increased chylomicrons, and most likely that could be type 1. If you remember, that was familial hyperchylomicronemia. If creamy layer and turbid, you have got a creamy layer, the infranatant is turbid. You can tell by putting a white paper on the other side. Then it tells you that that is most likely type 5. Increase the chylomicrons and a bit of VLDL. If the infranatant is turbid, that is below there is turbid, you cannot see anything else, then there is most likely increase the VLDL or intermediate density lipoprotein. And this could be either type 2B or type 4. If infranatant is clear, then what you have is a normal VLDL and LDL, and most likely you have got type 2A. Appearance of serum after refrigeration does not assess the levels of cholesterol, rich LDL, or HDL. So you cannot use serum and plasma refrigerated to decide whether the LDL or HDL is elevated. Though, where LDL is highly elevated, there is a possibility that the serum could look pinkish. And the reason why it looks pinkish is not exactly pink, but LDL is carried in the beta-2 region like carotene. So what you have here is a combination of the LDL and the carotene, which gives a yellowish, almost pink yellowish tinge. And you have got to be very good at identifying colors for you to say this is not light hemolysis or this is not icteric serum. And I think I'll go up to that point. You have got the notes with you. Just make sure you look at the reverse cholesterol transport again. It's important. Number 2, look at the hypolipidemias. Hypolipidemias are not very important clinically, but they are a good way of explaining some of the aspects of the hyperlipidemias. The L-carnitine deficiency, ApoC2 deficiency, hypo-beta lipoproteinemia, an alpha lipoproteinemia. An alpha lipoproteinemia is no HDL in plasma, and is common in what is called the Tajas disease. So look at them, and when we meet in the crack sheet, we can look at Liu cases. I think I have had 2 groups, and I was telling them that some of these things we said, they are going to be tied in this lecture. So it's important now, anybody who comes in for crack sheet is going to be easy to understand